Okay, so as you can see here, our topic will focus on the clinical pharmacology, treatment, drug therapy of Parkinson's disease. I am Dr. Khalid Hassan, Associate Professor of Clinical Pharmacology, Drug Therapy, and Clinical Research. Uh, okay, so for the Parkinson disease, it's like a progressive neurological disorder characterized by tremors, muscle rigidity, bradykinesia, slowness of movement, and postural and gait abnormalities. And normally, most of the case may be seen in people above age 65. The approximately incidence of this disorder or disease 1 in 100 individuals over 65 in the United States. Pathophysiology, this is an important topic for us because we build our treatment according to the pathophysiology. What they found there in the pathophysiology, we have destruction of the dopaminergic neurons in substantia nigra, and this result in the reduced dopamine action in the corpus striatum and affect the motor control as a part of basal ganglia system. So the main topics here, we're going to focus on the destruction and deficiency of dopaminergic neuron and dopaminergic activity. Okay, so first of all, we need to understand what the effect of dopamine in our body. As you know that we have two slides. The first one speaking about increased level of dopamine. The second slide is talking about decreased level of dopamine. As you can see here, if the dopamine increase in our body, the result will be stimulate vomiting center and causing nausea and vomiting. So the first one, the first one, if the dopamine increase, the dopamine will stimulate the vomiting center and induce nausea and vomiting. Okay, if you speak about mesolimbic pathway, you can see there that this will lead to hallucinations, delusions, and mood disturbances. This slide here talking about increased level of dopamine. Moving to the other, maybe on the other side, on the other hand, decreased level of dopamine. We have deficiency, we have decreased level of dopamine. This will lead to the effect on the corpus striatum and induce Parkinson disease. We have balance between dopamine and acetylcholine on the corpus striatum and substantia nigra. If the dopamine decrease, the result will be Parkinson disease. Or if you talk about the pituitary gland, we have inverse relationship between dopamine and prolactin. If the dopamine level decrease in the pituitary gland, this will stimulate the pituitary to release the prolactin. If the prolactin increase, this will lead to the infertility. This will lead to the hyperprolactinemia and maybe other side effect. So you can see here we need to keep the dopamine on normal level. This is in healthy subject, the dopamine level should be normal, because if any increase in dopamine level, the patient may suffer from nausea and vomiting. The patient may suffer from hallucination, delusion, and mood disturbances. If the dopamine decrease, the patient may suffer from Parkinson's disease, or patients suffer from hyperprolactinemia. Okay, we need, when you have patient with a Parkinson disease, before we start any treatment, we need to exclude drug-induced Parkinsonism. What that mean? We have some medication may cause symptoms like Parkinsonism, and we call this one pseudo-Parkinsonism. So we need to exclude. We need to figure out, does the patient take any medication? Okay, if we know that some medication may cause Parkinson disease, we can stop this medication or transfer the patient to another group of medication, and the situation will be reversible and the patient will be recovered from these symptoms. The most important agent, we have two main groups. We have butorphanone and phenothiazine, and these two medication belong to the drugs called antipsychotic drugs, and these antipsychotic drugs work by blocking dopamine receptor. If you go back to the slide, you can see here blocking dopamine receptor lead to the Parkinson disease. So antipsychotic medications such as butorphanone and phenothiazine block dopamine receptor and lead to the Parkinson or Parkinsonism, pseudo Parkinsonism. Another medication here we have reserpine. Reserpine also at high doses cause similar symptoms because reserpine lead to the depletion of dopamine in the brain. Okay, anti-Parkinson drugs here or anti-Parkinson drugs. This is the same list, but it's like divided into two. This list here in the right and left side, it's like speaking about medication. This list here speaking about medication used for treatment of Parkinson disease. We have amantadine, apomorphine, benzotropine, entagabone, estradiol, levodopa carbidopa, cinnamate. Then we have levodopa carbidopa, entagabone, opicabone. This is maybe the first part. The second part, anti-Parkinson drugs. We continue with the medication, anti-Parkinson medication, bromipixole, Mirabex. We have rasagiline, robirinol, rotogotine, sifenamide, selegiline, tolgabone, and trihexyphenidyl. So as you can see here, we have list of medication from A to Z belong to the anti-Parkinson drugs. Again, here in this maybe table here, they try to classify the medication according to the generic name, brand name, and the group of medication, class of medication. For example, we have a group of medication belong to the monoamino oxidase in B inhibitor, monoamino oxidase B inhibitor. Then we have catechol-O-methyl transferase inhibitor. Then we have dopamine agonist. And the last one we have anticholinergic drugs. So all these circle here we have a group of medication, but levodopa is only one medication. So you from the graph here you can see we have levodopa number one. We have when monoamino oxidase B inhibitor. Then we have catechol-O-methyl transferase, dopamine agonist. So we're looking for medication to enhance or increase level of dopamine in the brain. Dopamine agonists, we have a group of medications such as bromocriptine, bergolide, bromipixole, robirinol, anticholinergic such as trihexyphenidyl and benztropine, amantadine also available for the treatment. Okay, strategy for the drug treatment of Parkinson disease. The goal of treatment, number one, increase level of dopamine in the brain. So we look for to increase level of dopamine in the brain. What is the strategy of treatment Parkinson disease? Number one, increase level of dopamine in the brain. Number two, we try to inhibit muscarinic cholinergic activity in the brain. Number three, we can use a combination treatment between both. So number one, we try to increase level of dopamine in the brain. Okay, this is number one. Number two, we try to decrease atropine-like effect, try to inhibit muscarinic activity in the brain. Number three, okay, we have option to combine this medication together. So we have three approaches here: enhance dopamine, decrease atropine, or combination between two approaches. Okay, we will start with the first group of medication, levodopa, carbidopa, cinnamate. Cinnamate here is like a kind of combination. Levodopa is a precursor of dopamine. It's like prodrug. Levodopa, when the levodopa enter the body, will convert to the dopamine. So when the levodopa, okay, administered, the levodopa will convert to the dopamine. So we need to keep this in our mind. This one could be in the two places, could be in the central nervous system or could be in peripheral tissue. So we have it, levodopa convert to dopamine in two places, central nervous system and peripheral tissues. Okay, so you can see here levodopa precursor to dopamine and is capable of crossing the blood-brain barrier. So this medication able to arrive to blood-brain barrier. When that medication arrives to blood-brain barrier, this medication will be converted to the dopamine in the central nervous system. Okay, so when we prescribe levodopa, arrive to the brain, converted in the central nervous system to the dopamine, and this will lead to the restored dopaminergic neurotransmission in the striatum and enhance activity of dopamine and improve symptom of Parkinson disease. So you can see here we prescribe precursor like oral. This precursor leave the GI system, arrive to the blood, then to the brain, and the brain converted to the dopamine and restore the dopaminergic activity. Okay, so we have another medication always combined with the levodopa, and this medication called carbidopa. So as you can see, levodopa, carbidopa, we have the same suffix. Carbidopa is not medication to treat Parkinson's disease. Carbidopa is a medication that inhibits the enzyme called dopamine decarboxylase. So you can see here, carbidopa inhibit the enzyme called the dopamine decarboxylase. Okay, and uh, by inhibiting the dopamine carboxylase, that will prevent peripheral metabolism of levodopa, and this will lead to the increased bioavailability of levodopa in the brain. This will give two advantages for this combination. Number one, this will lead to reduce required dose of levodopa by 4 to 5 times or fivefold. Then they mentioned the adverse effect of peripheral adverse effect of dopamine. Because if the dopamine increase in the peripheral tissue, this will lead to the nausea, vomiting, cardiac arrhythmia, and hypotension. So this explains the reason for combination. So the purpose of combination carbidopa with the levodopa to inhibit the enzyme called dopamine decarboxylase, and this will prevent metabolism of levodopa in peripheral tissue and allow levodopa to increase bioavailability in the central nervous system. Okay, so the therapeutic benefit from this combination, effective restoration of dopamine in the brain, reduce adverse effect, enhance efficacy. So we have three main benefit. Effective restoration of dopamine in the brain, reduce side effect, peripheral side effect, and enhance efficacy of the therapeutic efficacy at lower doses of levodopa. Okay, this schematic graph here show us the tyrosine convert to the dopa convert to the dopamine enter the physical, then the physical arrive to the nerve ending here, and you can see the physicals release its content to the synaptic cleft or like synaptic gap. And when the dopamine release in synaptic gap, the dopamine molecules will bind to the receptor, and we bind to the dopamine receptor and produce the physiological action. Okay. Um, Moving to, so we have here target number one. This is target number two. Will be target number 3 and 4. So if we can look again what happened there on the our target for the treatment, we are going to focus on. You can see here number one, we look for the medication affect the dopa, and now we are going to prescribe levodopa as we discussed it in the beginning. We are going to describe. I'm going to write it like we have levodopa. Then we have other medication work on monoamino oxidase. So this kind of enzyme, monoamino oxidase kind of enzyme, and this enzyme responsible for metabolism of dopamine. Okay, so if you inhibit this enzyme, that means you are going to increase level of dopamine in the brain. Another enzyme responsible for metabolism of dopamine, we have two enzymes, monoamino oxidase, the first enzyme. The second enzyme, catechol-O-methyltransferase. We have some medication. If this medication inhibit this enzyme, so inhibiting monoamino oxidase lead to the increased level of dopamine. Inhibit catechol-O-methyltransferase, this will lead to the increased level of dopamine. So we have maybe two approaches here. So the other approach here, or final approach, number one, levodopa, number two, monoamino oxidase inhibitor, number three, catechol or methyltransferase, and the last one, dopamine receptor. So we try to use any medication activate this receptor, activate dopamine receptor. For this reason, we are going to use dopamine agonists. So as you can see here, we have four main groups for Parkinson's disease: levodopa, carbidopa as replacement therapy, monoamino oxidase inhibitor, catechol or methyltransferase, or dopamine receptor agonist. Four main groups for the treatment of um, Parkinson's disease. Okay, first medication, the roadmap for levodopa. Patient comes to the clinic, suffer from symptom of Parkinson's disease, and we decide to administer levodopa to the patient. But as you can see here, when you prescribe levodopa to the patient, levodopa has two main pathways. The first pathway that will go, levodopa will go directly to the brain. As you can see here, levodopa moving directly to the brain. But you can look on the arrow here at the thickness. The thickness of this arrow here, the thickness of this arrow, okay, represent the percentage of levodopa arrived to the brain. So this one here could be 20%, for example, or could be 30% of levodopa arrived to the brain, according to the thickness of this arrow. But you can see the thickness of this arrow here, which is represent the percentage of levodopa. We can see here around like 70 to 80, could be 90% of medication will be metabolized, will be destroyed, will be catabolized. So here we have maybe small amount of levodopa arrive to the brain, and the majority of the amount of levodopa will metabolize in the peripheral tissue by the enzyme called dopamine decarboxylase. So this enzyme available in two places, but here we talk about peripheral tissues, available in the gastrointestinal, in the GI system, and peripheral tissue also. So this enzyme, dopamine decarboxylase, is responsible for metabolism of dopamine. So here this enzyme responsible for metabolism and decrease, this will lead to the decreased activity of levodopa. How we can work on how we can maybe manipulate the situation here? They said the best way to increase efficacy and increase effectiveness, therapeutic effect of levodopa to combine with another medication. We try to inhibit the dopamine decarboxylase. So dopamine decarboxylase inhibit metabolism of carbidopa inhibit the enzyme called dopamine decarboxylase. So first I will repeat that. We prescribe carbidopa with the levodopa because carbidopa intend to inhibit this enzyme, dopamine decarboxylase. Inhibiting the enzyme dopamine decarboxylase, this will limit the amount of dopamine metabolized in the peripheral tissue. So you can see here we have decreased amount of dopamine metabolized in the peripheral tissue and increase amount of dopamine arrived to the brain. This enhance efficacy of dopamine and enhance arriving the dopamine to the brain. So enhance the activity, enhance therapeutic effect. So the main purpose of combination levodopa carbidopa to decrease degradation, decrease metabolism, and enhance activity of levodopa. Okay, levodopa carbidopa cinnamon used primarily for the Parkinson's disease, and they found when you use this medication, the result will be decreased rigidity, decrease the tremor, and improve symptoms. And what they found here, and this reduced severity of symptoms approximately happened in 2/3 of patients in the first 5 years. So when you prescribe it during the first 5 years, the patient, the relatives, the family will be happy because the symptom improved from the beginning of treatment or to the first few years of the treatment. But later on they found, because this case, Parkinson's disease is like progressive disease. What they found here after maybe 3 to 5 years, the symptom will be worsening again, and we have declined response to the medication after 3 to 5 years, because the disease considered like progressive disease and deterioration disease. Okay, speaking about PK stand for pharmacokinetic. Here we focus on some uh, b- b- pharmacokinetic perspective. For example, they said half-life for levodopa 1 to 2 hours, leading to the fluctuation in the plasma. This one leading to the fluctuation in the plasma. That means when you have fluctuation in the plasma, I will go with the, for example here, okay, this one here, this is a dopamine, or I will say, for example here, levodopa concentration, blood concentration. Here we have the symptoms of Parkinson disease. Because we have this fluctuation here in the levodopa, the symptoms here will be improve, worsening, and so on. So we have the maybe the reflect the what happened on the clinical symptoms, because the fluctuation of levodopa, the symptoms and signs will be fluctuation also. Levodopa, they found some food may interfere with levodopa, such as high protein meal with interfere with the levodopa, and for this reason we advise patient to take this medication on an empty stomach, typically 30 minutes before meal. Okay, some adverse effect, all these adverse effects related to the increased level of dopamine. So levodopa may cause side effect due to the increased level of dopamine. Okay, most of these one. Dopamine, because dopamine increase stimulate CTZ. CTZ stands for chemoreceptor trigger zone, and this will lead to the anorexia, nausea, and vomiting. Very important. Dopamine cause nausea, anorexia, and vomiting. Dopamine could be stimulate dopamine receptor in the cardiovascular system, and this will remind us with the epinephrine, because dopamine convert to the epinephrine, and we know that epinephrine cause tachycardia. Dopamine cause hypotension and vasodilation. Dopamine activate adrenergic receptor and cause mydriasis. Mydriasis mean increased diameter of the pupils. If you speak about mydriasis here, and this is the eye here, talk about the eye, and this is a mydriasis. Okay, so speaking about the eye, so what happened here, the effect of adrenergic here, so the situation will be the mydriasis, increased dilation of the diameter of the iris here due to the maybe contraction of radius muscles or radius fiber. So the patient suffer from mydriasis. Brownish saliva and urine from the melanin pigment produced from the catecholamine oxidation. So here we need to maybe educate the patient not to be worried about changing the color of saliva or changing the color of urine. Also, patient may suffer from some hallucination or involuntary movement, sometimes such as dyskinesia. Mood changes, depression, psychosis due to the increased level of dopamine. So when the dopamine level increase, the patient may suffer from these symptoms here. All these like related to the adverse effect of levodopa. Okay, another important aspect we need to look at, we have levodopa interaction. We have vitamin B6 pyridoxine. Pyridoxine may interact with the metabolism of levodopa in peripheral tissue. They found vitamin B6 may increase metabolism of levodopa in peripheral tissue and decrease effectiveness. For this reason here, we don't recommend patient to use maybe at the same time levodopa and vitamin B6, because this will decrease the efficacy of or effectiveness of levodopa. Number two, we don't recommend to use antipsychotic with the levodopa, because antipsychotic medication decrease dopamine, Antipsychotic medication decrease dopamine. Antipsychotic medication considered like dopamine antagonist, and this worsen the symptoms, worsen the symptom and consider contraindication. This is number two. Number three, we have monoamino oxidase is non-selective. I would like to mention something important here. Uh, we have levodopa convert to the dopamine. Okay, this is our medication. They said if the patient take monoamino oxidase non-selective such as phenlizine, so phenlizine here, and this will lead to the increased level of dopamine. So we have two medication, both of them increase level of dopamine, and this will lead to the, okay, we know that from here dopamine will convert to the epinephrine, and you can tell me what happened to the blood pressure. What do you think? Severe hypertension. Can we call this one hypertensive crisis? Yes. For this reason, we don't recommend to use levodopa and non-selective monoamino oxidase inhibitors such as phenlizine. So we have the situation here. Again, another issue here, if the patient suffers from cardiac disease, levodopa will increase level of developing of cardiac arrhythmias. So this drug interaction very important for us. Vitamin B6 interact with the metabolism in the peripheral tissue, decrease efficacy. We discussed the antipsychotic, cardiac patient, and psychotic patient. Okay, we'll finish with the first group of medication. We discussed levodopa, carbidopa all together. Move to the second group, monoamino oxidase inhibitor. We have selegiline, rasagiline, cefinamide. Selegiline, rasagiline, cefinamide, and this belongs to the monoamino oxidase inhibitor. Okay, in order to understand when we talk about monoamino oxidase, we have two types. Okay, monoamino oxidase A and monoamino oxidase B. They said monoamino oxidase A mainly responsible for metabolism of norepinephrine and serotonin. On the other hand, monoamino oxidase B mainly responsible for metabolism of dopamine. So the second group of medication for Parkinson's disease is going to affect the or inhibit monoamino oxidase B. So inhibit monoamino oxidase B, this will lead to the increased level of dopamine in the neurons and in the brain and enhance improve symptoms of Parkinson's disease. How this medication work, you can see it here. This is the enzyme monoamino oxidase responsible for metabolism of dopamine. Okay, here I need to address something important about dopamine and dopamine metabolism, dopamine pathway. For example, what we have so far, you can see here we have dopamine. Okay, the dopamine will affect the receptor and produce actions. This is desired effect. At the same time, we have two main pathway for the dopamine, two main pathway. The first one, monoamino oxidase B. Then we have catechol or methyltransferase. Okay, so we have two main, we have three fate to the dopamine. So here, this represents the fate of dopamine. What happened here? If we inhibit the monoamino oxidase, we are going to inhibit this pathway here. Okay, the result will be enhance the activity of dopamine and activate the receptor, improve symptom of Parkinson's disease. This is number one. Another one, okay, what happened if you inhibit the catechol or methyltransferase? If you inhibit this one, this will lead to the inhibit this pathway. Also, this will enhance activity of releasing dopamine, binding to the receptor, and improve symptom of Parkinson's disease. From this whiteboard here, we can see the three pathways for dopamine. Number one, dopamine will release in the synaptic. This is a neuron here. The dopamine will release from the synaptic, and then binding to the postsynaptic, binding to the target tissues, produce action. We have two main metabolism pathway: monoamino oxidase and catechol or methyltransferase. We have some medication able to inhibit monoamino oxidase and catechol or methyltransferase. If you inhibit monoamino oxidase, the result will be enhanced release of dopamine in the postsynaptic and improved symptom of Parkinson. If you inhibit the catechol or methyltransferase COMT, the result will be inhibit this pathway metabolism and enhance release of dopamine. So if we need to maybe understand what happened here and why we have this compensatory mechanism, maybe we can look on this as follows. For example, you can imagine we can imagine together ourselves. We have main river here, main river, and this river divided to two branches, and we have this branches here for the river. This is the main river here, and this the main river represent the dopamine. Okay, the first branch of this river monoamino oxidase B, and the second branch will be catechol or methyltransferase, and the main river coming there. So what happened here? And then we have another branch from in the middle here. I will clean it a little bit. Okay. Okay, this represents the going to the target here. Okay, so clean this one here. Target. So you can imagine here we have the dopamine moving. Okay, if you close or if you block one of these branches, this will lead the flow of dopamine toward the target. What happens if you inhibit catechol or methyltransferase? The same situation. This will enhance the efficacy of dopamine. Okay, shall we discuss the medication used for Parkinson's disease by affecting monoamino oxidase B? We have three medication. We have selegiline, rasagiline, sulfonamide. This medication, monoamino oxidase, inhibit monoamino oxidase B, and this will lead to the enhance. You can see it here, two main pathway now. If you inhibit the metabolism, this will enhance the activity of dopamine. This will increase level of dopamine in the brain and maybe improve symptoms of the Parkinson's disease, enhance the action of levodopa, and may reduce the dose for levodopa also. So these medication, if you prescribe selegiline with levodopa, this will lead to the enhanced action of levodopa and reduce the dose for levodopa. Okay, the second enzyme, catechol or methyltransferase. Okay, here in this table here, like comparative studies. Okay. Okay, this table here present comparative study between monoamino oxidase inhibitor. We have selegiline, debrenil. Okay, we have selegiline, debrenil, rasagiline, azilect, and then we have Xadago, sulfonamide. What are the difference between all three medication here? The first medication, irreversible, lead to the irreversibly selective MAO inhibitor, irreversibly inhibit monoamino oxidase. The first medication. The second medication irreversibly maybe inhibit monoamino oxidase. Sulfonamide reversibly inhibit monoamino oxidase. So now we can tell the difference between the selegiline, rasagiline, sulfonamide. Okay, moving to that, maybe the second characteristic here. Selegiline, debrenil, metabolized to the methamphetamine and amphetamine will lead to the stimulant effect. So the patient here may suffer from stimulant effect. On the other hand, if you move to the rasagiline does not metabolize to the amphetamine and amphetamine, and there is no risk of stimulant effect. Okay, now we have some characteristic here. Rasagiline more potent than, like 5 times than the racilogilline. So three characteristic: reversible, 5 times more potent, no potential of stimulant effect, rasagiline. What about sulfonamide? Sulfonamide reversibly inhibit monoamino oxidase, no potential of stimulant effect. Not only monoamino oxidase will be affected by Xadago or sulfonamide, also they found this medication inhibit glutamate release and dopamine release. So two things will be inhibited: dopamine. Um, this one inhibit monoamino oxidase B by sulfonamide and inhibit glutamate with the sulfonamide. Okay. Okay, I would like to share the screen with you. This one from the NIH National Library Medicine about Zedego, sulfonamide, and it's ruled out about the mechanism of action. This anti-Parkinson medication, sulfonamide, is through the reversible inhibition. So we have it here, reversible inhibition of monoamino oxidase. In addition to that, they found this medication also inhibit glutamate release and dopamine reuptake on the brain. So we have two main mechanisms related to the medication, sulfonamide, two main mechanism. Okay, we're done with the second group. The first group was levodopa, carbidopa. The second group, monoamino oxidase inhibitor. We have three medications: siligiline, rasagiline, sulfonamide, and we compare between three medication together. Moving to the third group of medication for Parkinson disease, we have catechol-O-methyltransferase, COMT inhibitor. Two medication we have it there. We have entagabone and tolgabone. Before we speak about how this medication work, okay, they said tolgabone carry the risk of serious fulminating hepatic necrosis, hepatitis or hepatic necrosis. Tolgabone, serious fulminating hepatic necrosis. Entagabone does not cause this toxicity. This is a better pharmaceutical profile. Entagabone, better tolerated. Tolgabone carry the risk of hepatic necrosis. Okay, how this medication work? As you can see here, we have enzyme called catechol-O-methyltransferase responsible for metabolism of levodopa to 3-methyl-dopa. So with the COMT inhibitors inhibit this enzyme. This will lead to the increased efficacy, increased dopamine level in the brain. So another way we can see it here, increased level of dopamine in the brain. Okay. This here with the arrow, that mean enhanced activity of dopamine in the brain. Okay, so again in this slide here you can see we have the dopamine release to the synaptic. Then we have two enzymes responsible for metabolism of dopamine. We have monoamino oxidase B. We have catechol-O-methyltransferase. And our medication in this section here will be catechol-O-methyltransferase inhibitors such as entagabone, tolgabone, and this will improve symptom of Parkinson disease and enhance activity of levodopa and reduce dose for levodopa. Again, we spoke about that tolgabone may carry the risk of hepatic necrosis, and this risk does not happen with the entagabone. Okay, you can see here that entagabone and tolgabone inhibit the enzyme called catechol-O-methyltransferase, and this will enhance release of the dopamine in the synaptic and improve symptoms of Parkinson disease. Okay, this is an important slide for us, very important slide. We have three main organs, three main tissues: peripheral tissues, brain tissues, then we have blood-brain barrier. So you can see here when you prescribe levodopa to your patient, levodopa maybe will face several pathways. We know that in the peripheral tissue we have enzymes such as dopa decarboxylase, And we have another enzyme, catechol O methyltransferase. COMT available in the peripheral tissue, this enzyme, and available in the brain. Okay, then we have another enzyme, monoamino oxidase B, on the brain. So all these like consider like enzyme, all these enzyme, four enzyme, three enzyme, but it's like four sites. Three enzyme, number one, monoamino oxidase B, catechol O methyltransferase, dopa decarboxylase, and COMT available in the peripheral. So we can see we have some duplicate here between COMT and then we have monoamino oxidase decarboxylase. Okay. Okay, when you prescribe dopamine, you can see here, for example, if we prescribe 100 milligram of levodopa to the patient, could be like 20% arrive to the brain, and another 80% will be metabolized in the peripheral tissues and in the brain. We try to improve the concentration of dopamine arriving to the brain. Okay, let us look on the site of action, the action of drugs here. As you can see, we can, number one, we already discussed, we can use carbidopa. Carbidopa inhibit the enzyme responsible for metabolism of levodopa. Carbidopa inhibit dopa decarboxylase. Okay, and this will allow us to keep the levodopa intact and allow the levodopa to maybe prevent from metabolism by this enzyme, allow more levodopa to arrive to the brain, cross the blood-brain barrier, arrive to the brain, and this number one. And another type of medication will be catechol O methyltransferase. You can see it here. We have two medication, antagabon, tolgabon. This two medication inhibit the COMT, allow more levodopa to cross and arrive to the brain. So two medication will enhance arriving levodopa to the brain. Number one, carbidopa inhibit dopa decarboxylase. Antagabon, tolgabon inhibit catechol O methyltransferase. Now levodopa arrive to the brain. Okay, on the brain we have three pathways. Levodopa binding directly to the receptor. Number two, levodopa will be metabolized by the enzyme called monoamino oxidase B. Number three will be metabolized by COMT. For this reason here we can prescribe antagabon, tolgabon again. So antagabon, tolgabon maybe affect two main sites, could be inside the brain, could be in the peripheral tissue. You can see the enzyme available inside the brain and in peripheral tissue for the antagabon and tolgabon. Monoamino oxidase, okay, this medication affects mainly the brain. We have selegiline, rasagiline, sulfonamide, and we discussed the characteristic of each of these medication and the table before. This kind of enzyme inhibit monoamino oxidase and enhance activity of dopamine arriving to the receptor, and maybe allow more dopamine to arrive to the brain and to the receptor and activate the receptor. Okay, another option here, another option we have it here. We are going to discuss it. Maybe the last resort for us. We can use some medication able to stimulate the dopamine receptor. We have some medication able to bind and stimulate the receptor. This will be great. So as you can see here, we have bromocriptine, pergolide, we have brambixol, robirinol, and we have other group of medication. So this slide here is very important slide because this slide show us the site of action of medication: carbidopa, antagabon, tolgabon, or monoamino oxidase inhibitor, selegiline, rasagiline, sulfonamide, bromocriptine, pergolide, brambixol, robirinol. If someone asks what is brambixol, brambixol is considered like dopamine receptor agonist. What is the bromocriptine? Bromocriptine dopamine receptor agonist. What is antagabon? Antagabon catechol O methyltransferase used for Parkinson disease. Antagabon, tolgabon, catechol O methyltransferase inhibitor. We need to complete the sentence here. Okay, comparing between the medication available for us, dopamine receptor agonist. If you go back there to the previous slide, we are going to speak about dopamine receptor agonist here. Okay, moving to the slide here, we have two main group. We have for dopamine receptor agonist, we have two many group, an ergot derivative and ergot derivative. So dopamine receptor agonist used for Parkinson disease, we have an ergot derivative, one medication bromocriptine, non-ergot derivatives such as roperidone, brambixol, rotogotine, and apomorphine. What is the advantage for this medication? Any advantage for this medication? I will repeat that. For dopamine receptor agonist, this is a group of medication used for Parkinson disease. We have two main group. We have ergot derivative, represented by bromocriptine, non-ergot derivative. We have roperidone, brambixol, apomorphine, and rotogotine. So this is a group of medication considered like dopamine receptor agonist. Advantages, yes, this medication provide advantages if you compare it with the levodopa. Number one, these medication have longer half-life, longer duration of action, effective in treating patients who present the fluctuation response to levodopa, are not able to control Parkinson disease on levodopa, and this group of medication less risk of developing dyskinesia and motor dysfunction. So we have several characteristics, several benefits. Number one, longer duration of action. Number two, effective in patient exhibiting fluctuation response to levodopa. Number three, less risk of developing dyskinesia and motor fluctuation. Okay, speaking about bromocriptine, as you can see if you go to previous slide, bromocriptine considered like ergot derivative, and if someone maybe for the ergot, what that mean? Here we are talking about ergotamine. If you remember that, I recommend you to ergotamine, derived from the ergot or ergotamine, and I recommend you to review the migraine lecture regarding ergotamine because it's closely related. We know that ergotamine cause is something called vasoconstriction, and there is a risk of gangrene or like ischemia coming from ergotamine because ergotamine causes vasoconstriction. Okay, here we try to, in this slide here we try to compare between dopamine receptor agonist, between bromocriptine as an ergot derivative and non-ergot derivative drugs. So the bromocriptine considered like the ergot derivative drugs, and because the bromocriptine considered like ergot derivative, there is a risk of peripheral vasoconstriction and risk of myocardial infarction. We don't prefer to use it. We have to practice cautious when you prescribe it to the patients from myocardial infarction or peripheral artery disease. This group of medication, bromocriptine, carry the potential risk of pulmonary fibrosis and retroperitoneal fibrosis. So we need to remember that maybe the hallmark, the characteristic or the adverse effect, the drawback coming from bromocriptine. Bromocriptine may cause pulmonary fibrosis. Bromocriptine may cause retroperitoneal fibrosis. Okay, moving to the second group of medication. Moving to the second group of medication, as you can see it here, we have dopamine receptor agonist, non-ergot drugs. We have brambixol, roperidone, rotogotine, and apomorphine. So we are going to maybe speak about the main characteristic for each medication. They said brambixol, roperidone, rotogotine. These three medication used for Parkinson disease. That's one. Another case, restless legs syndrome. So I'm going to maybe review it with you maybe in the next slide. So Parkinson disease and restless leg syndromes, brambixol, roperidone, available orally active agents. We are going to see it together. Then we have rotogotine, available like transdermal delivery system. The last one here we have apomorphine. Apomorphine available like injectable medication. When we talk about injectable, we use it for severe and advanced stage of Parkinson disease. Okay, so we are going to click on the link here and maybe discuss with you what happened there. I will click on the link. Okay, so this is the link coming from the website, and you can see here the medication roperidol, and maybe we can maximize it a little bit. Okay, roperidol. Okay, this is a roperidol Requib tablet, oral tablet roperidol. This medication approved by the FDA 1997. Indication, you can see it, you can take it with food or without food. This medication used for Parkinson disease, as you can see. This medication, roperidol, non-ergoline dopamine agonist, indicated for Parkinson disease, moderate to severe restless leg syndrome. So we have two cases here. We need to remember it. Okay, back to the slide. Again, if you go back, so you can see roperidol for Parkinson disease and restless leg syndrome. Another group of medication, we have pramipexole. So you can see, remember here, roperidol for Parkinson disease and restless leg syndrome. Again, maximize the page a little bit to show you what we have. Pramipexole, Mirabex, pramipexole tablet, orally active tablets. Indication the same, Parkinson disease and case of restless leg syndrome, available as tablets. Okay, moving to the maybe third medication. Okay, apomorphine, maximize. Apomorphine subcutaneous injection. Apomorphine. We use it for, yes, non-ergoline dopamine agonist indicated for acute intermittent treatment of hypomobility. If you are maybe a little bit confused, I will indicate, go to, maybe scroll down. Okay, if we can read the information here for this medication, apomorphine hydrochloride injection indicated for acute intermittent treatment of hypomobility in a patient with advanced Parkinson disease. So the question now, I will go back to the slide here. This is the slide here. Which of these medication, if we clean the board here, the whiteboard, if we clean it, okay, which of these medication could be used for Parkinson disease to treat advanced stages, not response to the maybe classic treatment? I will go with the answer here with apomorphine available like subcutaneous injection. Okay, please remember apomorphine injectable for use for severe advanced stages of Parkinson disease. The last one here. Okay, the last one, rotogotine, and the brand name Neabro. So you can see it here as a Neabro rotogotine available like transdermal patch. Okay, transdermal patch, if you go back again to the slide. Okay, which of these medication available like transdermal patch we use it for Parkinson disease? Rotogotine. So now we have oral tablet. Okay, transdermal patch, and then we have injection here. So we need to remember the cases here according to the situation. Bromocriptine, we discussed the ergot and the effect of ergot and pulmonary fibrosis. Regarding the dopamine receptor agonist, we discussed the available orally, for example. We discussed the restless leg syndrome, and we discussed the transdermal patch and injectable for the severe advanced stages of Parkinson disease. This is the last slide for Parkinson disease. We have another group of medication. We have amantadine. Amantadine considered like antivirus medication. This medication provide benefit for Parkinson disease through several mechanisms. Amantadine increase release of dopamine. You can see it here. Increase release of dopamine. Increase release of dopamine. Number one. Number two, blocking cholinergic receptor. Number three, inhibit NMDA type of glutamate receptor. So three main mechanisms of amantadine. Amantadine antivirus medication increase level of dopamine. Number one. block a cholinergic receptor and inhibit NMDA receptor glutamate. This medication, amantadine, may cause hallucination, psychosis, but they said, we have it here, amantadine less efficacious than levodopa. Levodopa remained the first choice for treatment. The first choice treatment for Parkinson's disease, levodopa. Levodopa, carbidopa, cinnamon. Then we have levodopa, carbidopa, and tagabone. So we have several levodopa, carbidopa, and tagabone, or levodopa, carbidopa, and siligilene. And we have anti-muscarinic medication. Moving to the anti-muscarinic medication for Parkinson's disease, we have two medications, benztropine, 3-hexphenadiol. Even with this medication, remain less efficacious than levodopa and considered like adjuvant therapy for Parkinson's disease. We need to remember that by blocking the cholinergic transmission, this will lead to the enhanced activity of dopaminergic neurons. So blocking the cholinergic neuron, this will lead to the enhanced efficacy or the effective of dopaminergic neurons. At the end of this lecture today, I would like to summarize what we already talked about. We discussed the Parkinson's disease as an overview, discussed the symptoms, signs, the incidence, the pathophysiology. Then we discussed the fluctuation or changes in the dopamine level, even increased dopamine and decreased dopamine, what happened, what is the consequences. Then we moved to the drug-induced Parkinsonism, such as pseudo-Parkinsonism, especially talking about butorphanol and phenothiazine. Then we discussed a list of medication used for treatment of Parkinson's disease. Please remember, we don't have a cure of Parkinson's disease. The list of medication include amantadine, apomorphine, benzotropine, antagabone, levodopa, carbidopa, antagabone in one tablet. Then we have bromboxol, rasagiline, roberinol, safinamide, and siligilene. Also, we discussed how this medication work, and we have hands-on on the neurons, how this medication affect, side effect, drug interaction for levodopa. We have the graph there, and we discussed the metabolism of levodopa in the peripheral tissue and in the brain. And then we move to the monoamino oxidase for three medications, siligilene, rasagiline, safinamide. We need you to differentiate between three medication here. What is the difference between siligilene, rasagiline, safinamide? Which of these medication is considered like irreversible? Which one reversible? Which of these medication carry the risk of stimulant effect by increasing to amphetamine and methamphetamine in the body? Okay. Then we discussed more catechol-transferase, antagabone, tolgabone, and we discussed one of these medication may cause hepatic necrosis. Move to the dopamine receptor agonist. We have two main group, ergot, non-ergot. Ergot, we have one medication only, bromocriptine, and bromocriptine because bromocriptine belong to the ergot derivative. There is a risk of vasoconstriction. There is a risk of pulmonary fibrosis, retroperitoneal fibrosis. Dopamine, other non-ergot dopamine receptor agonists, we have bromboxol, roberinol, and apomorphine. We discussed which of these non-ergot dopamine receptor available oral, which of these available like transdermal delivery system, which of these available like injectable for severe advanced stages, and so on. And the last one was amantadine and benztropine for the anti-muscarinic effect. Amantadine was antiviruses, and they found it carry the effect of anti-Parkinson with several medication. At the end of this lecture, thank you for joining us today in discussion on Parkinson's disease. We covered the key aspect of this condition, from its symptoms and causes to the latest treatment and research advancement. Remember why Parkinson can be challenges. There are many resources and support system available to help those affected patients. If you found this video helpful, please give a thumb up and share it with others. Subscribe to our channel. for more informative content. Together we can raise awareness and support the journey towards a cure. Stay informed and take care.